Κυρίες και κύριοι συνάδελφοι, θέλετε να καθίσετε να αρχίσουμε. Τα θέματα είναι πάρα πολύ ενδιαφέροντα και τα δύο. Και θα σας παρακαλέσω, επειδή οι δύο ομιλίες δεν έχουν σχέση μεταξύ τους ιατρικά, μετά την πρώτη ομιλία θα μπορούμε να κάνουμε ερωτήσεις και να συζητήσουμε ορισμένα θέματα που οπωσδήποτε θα υπάρχουν και μετά θα προχωρήσουμε στη δεύτερη ομιλία. Η πρώτη συνάδελφος η οποία θα μιλήσει για το non-invasive prenatal diagnosis of chromosomal abnormalities, η κυρία Alexandra Benachi, είναι Head of the Department στο Hospital Antoine Béclère, στη Γαλλία. Έχει εξειδικευθεί στα θέματα της εμβριομητρικής ιατρικής και περιγεννητικής ιατρικής. Εγώ την ξέρω αρκετά χρόνια. Είναι πάρα πολύ γνωστή στην Γαλλία και στο εξωτερικό για τις μελέτες τις οποίες έχει κάνει και ιδίως τώρα έχουν το πρώτο κέντρο που ασχολείται με το non-invasive prenatal diagnosis. So, Mrs. Benachi, it's our pleasure to have you in this hospital, and we are very proud that we include you in the scientific program of our hospital, and we want you to give a lecture on non-invasive prenatal diagnosis of chromosomal abnormalities. Please.
Good morning. Thank you very much for the invitation. It's a real pleasure for me to give a talk in the country of my ancestor. Although I have a very Greek name, I don't speak a word of Greek. I apologize. So I have to give the talk in English. I'm going to talk about non-invasive prenatal testing, as we don't really know whether it's a screening or diagnostic test. The English have used the word testing, which is much easier, and you're going to see why. I'm going to go a little bit into technical matters, but also I'm going to talk about the French experience and the conclusion that we have after our experience. As soon as a woman is pregnant, there is fetal DNA everywhere, in her blood, in the cerebral fluid, in the saliva, in the urine. And we know all this thanks to Dennis Lowe, who is a biologist in Hong Kong. He was working in the oncology lab, and he was studying the DNA coming from tumors. And he decided that he had these bright ideas that the fetus was a kind of tumor, and that probably when the woman is pregnant, there is DNA from the fetus in her blood. So he performed PCR on the Y chromosome, who definitely is not the mother's chromosome, and find out that woman carrying a boy had a positive PCR. So this was in 2007, less than 10 years ago. Fetal DNA comes from the cyto- und syncytiotrophoblasts, so it comes from the placenta, and this is very important because, as you will see, we will never have a karyotype of the fetus, but only a karyotype from the placenta. We can detect it from 5 to 6 weeks, but basically we don't do the sampling before 10 weeks because lower than that we don't have enough amount of DNA. The amount increases with gestational age, so the further in the pregnancy you do the test, the better are the results. This DNA disappears after birth. After 16 minutes after birth, you don't have any more DNA in the blood. And this is very important because you can use it even if the woman has been pregnant before, which is not the same with some of the fetal cells. There is very low amount of fetal DNA, and this fetal DNA is mixed with the maternal DNA, and there is absolutely no way to separate both. And this is very important. The fetal fraction is about 5 to 10% of the whole DNA of the mother, and the amount of fetal DNA varies with different factors, and we have learned with time and with errors to understand what was the factors that could influence this fetal fraction. First of all, the gestational age, but also the body mass index of the mother. For obese women, it's a real problem because there is a large amount of maternal DNA compared to the fetal DNA. We know also that when there is a chromosomal abnormality, the amount of DNA is generally very low. And also probably there is modifications in some ethnic group, but this is still under study. We cannot isolate this DNA, and this is one of the main problems that we've been through the past 10 years. What we know to do in a routine basis, at least in France, we're using it in routine, is the qualitative analysis of this fetal DNA. We know how to determine fetal sex of the baby. In France, it's absolutely restricted to women who are at risk of giving an X-linked disorder to their fetus. We cannot use it on a regular purposes for every pregnancy. It's definitely not possible, at least in France. But for those women, we can offer this test, and it allows not to do a CVS to know the sex of the baby. So it's a great improvement in the care of those women. We also offer this test to rhesus negative mother. Whenever you are rhesus negative, you don't have the genes in your blood. That means when the fetus is positive, the PCR will be positive, and it can come only from the fetus, not the mother. So we can offer this test also to rhesus negative women. We know also how to detect mutation located only in the fetus and none in the mother, like achondroplasia or thanatophoric dwarfism. We know also how to do those diagnostics in the mother's blood. And there has been 4 years ago a huge technical rupture with the appearance of the possibility to do quantitative analysis, and therefore we've been able to do detection of aneuploidies. Screening for trisomy 21, I'm going to give you the French results, probably are the same as yours, but in France we have an agency, which is called Biomedical Agency, and every year we have the results of all the screening tests in France. And it's a bit different than in the States, so I don't know if it compares with your techniques, but we do it this way. We only do first trimester diagnosis since 1909, which is 2009, which is not that far ago. And we use first trimester diagnosis now for all patients. It's mandatory to offer the test, but the test is not an obligation for patient. But every doctor have to offer the test to the patient. We have to do it according to the law, but the patient doesn't have to accept. So we do first trimester screening, as most of you probably, between 11 and 13 plus 6 days. We do a combined screening, and the patients are considered as at risk when the risk is higher than 1 in 2050. For example, in England, it's 1 out of 150. I don't know what you do in Greece. With this procedure, we detect 96% of fetus with trisomy 21 with a false positive rate of 5%. And those results are very important when we're going to compare with the use of the non-invasive testing. In France, we have to do, for women who would have a risk higher than 1 in 250, in those populations we've performed in 2012 22,000 invasive procedure. And how out of those 2,000 procedure, we detected only 4.9% of unbalanced chromosomes. Okay, and that's probably the same in your country, it's the same in England, it's the same in the States. Meaning we do a lot of sampling with a 1% miscarriage-related risk. Okay, 1%, it's huge. It's more than 200 babies each year that miscarriage because we do the sampling. And we detect only 4% of unbalanced chromosome. If we put the figures differently, we have in France, out of 800,000 delivery, there is 600,000 serum screening performed by the doctors. We have 4.5% of patients who have a risk higher than 1 out of 250. 22,000 sampling performed, as I said. There is 3.1% false positive, a woman with the screening positive, but the baby is normal at the end. That means theoretical miscarriage around 200 and a positive predictive value only of 5%. That means you have to do 20 sampling to have 1 trisomy 21 fetus. And that's the best screening we have actually, and it's far from perfect, okay? But that's what we offer to our patient. The technical rupture came with the non-invasive test for trisomy 21. The whole system works on one principle, very simple. It's the quantification of the number of fetal chromosomes. At the beginning, there were two different approaches. First, with specific fetal marker, we used RNA from the placenta or epigenetic markers, but it was quite difficult to reproduce and cost a lot of money. And the real technical rupture come from the non-specific quantitative approach with the use of massive parallel sequencing. And since this technique appears, we can do the diagnosis of trisomy 21, trisomy 18, and trisomy 13 in the maternal blood. It's a non-specific quantitative analysis, and the challenge is to be able to see the over-representation of circulating fetal DNA when it carries an aneuploidy. And the whole process is based on this knowledge. Thanks to Denis Lowe again and Stephen Quake from Stanford, in 2008, there was the two Princeps publication that have shown that using MPS, we can do the diagnosis of trisomy 21. The concept is to measure the chromosome fraction and to compare statistically with the expected value on a normal female with carrying a fetus. And there is two things that are important. So first of all is the number of cycles used, because the difference between the mother who will carry a fetus with a trisomy 21 fetus and the mother with a normal fetus will be so small, we have to amplify the genes over and over and over, amplify the DNA with millions of cycles. And the more cycles we perform, the bigger we will see the difference between the patient. Okay, this is the same amount, the same sample, but this is less cycles than this one. This one is, we use millions of cycles, and also we can differentiate the very small amount of chromosome difference between the two patients. The other thing is the fetal fraction. The higher the fetal fraction is, the easier we'll see the difference. Okay, so we need lots of cycle. This is why it's called massive parallel sequencing, and a lot of fetal fraction. Another way of putting it is we need to. This is a normal mother with a normal fetus with this DNA of the fetus mixed with a load of maternal DNA. And you have here the fetus with trisomy 21 who have a little extra fragment of DNA. And what does the MPS? The sequencing tells you which chromosomes come, from which chromosome comes the fragment of DNA. And so we can sequence for many sequences, and it gives you which chromosome from the extra part of fetal DNA. The problem is the fetal DNA, the DNA coming from the chromosome 21 is a very small amount of the whole chromosome. It's only 1.35%. So that's why we need to amplify for many cycles. MPS does not differentiate which fragment comes from the mother and which comes from the fetus. And this is very important. I was talking to you about this before, is that there's no way we can differentiate the DNA, but it doesn't matter, because we just go to check the difference in the whole amount of DNA. So the quantitative over-representation of trisomy 21 fragment is in an affected pregnancy is significant and can be measured with high precision. Okay, we're going to check for these extra DNA here. It's quite a revolution in medicine, because it never happened like this before. It's not a small lab in a country that have discovered this and have put it into the general public. It's millions of dollars invested by companies that have been built only to the purpose to do MPS for trisomy 21. And those companies are all over the world, basically in the States and in China. And this is interesting, because when you look into the literature, you can see that it comes from obstetricians, but it also comes from those companies. So it's not doctors that have been put this technique to general population, it's huge companies. And there is basically a few companies here, if you're interested by the names, but I'm sure most of you know them. And some of them have used the whole genome. That is, they can be, theoretically, they can detect any chromosomal abnormalities, but we only give the result for 13, 21, and 18. And some other techniques have used targeted MPS. That means they only look for chromosome 21, 18, and 13. It doesn't really matter, except that the targeting is quite limited, but it's less expensive and it's fast, the results come faster. But when you look At the no results patient, a few amount of patients, we won't be able to give the results. And with the targeted technique, there is about 5 to 12% of patients for which we won't be able to give the results. And if one day we use those techniques on a large screening technique, we won't be able to use it because it's far too much. The whole genome technique, we have between 1 and 2% of no results, which is very low. 2 years ago, the American College of Obstetrics and Gynécology have setting guidelines about using this technique, and they say that this technique should be an option for patients after informed consent, but this technique could be only used in high-risk patients, because at first, all publications that have been published about the subjects were on high-risk patients. And this is very, very important because it's not absolutely easy to translate a technique that has been done on high-risk population and to use it in general population, because everything depends on the prevalence of the disease you look for. And in a high-risk population, the prevalence of the disease is very high, while in the general population it's very low. And the indication for this test were maternal age over 35, fetal anomalies are ultrasound, and you're going to see that in France we don't use this technique for this indication, and I think it is not a right indication. History of prior pregnancy with trisomy 21, positive test after the screening, of course that's the best one, and balanced Robertsonian translocation. So we are using this technique in France. It's a very technical slide, and I'm an obstetrician, and so I know nothing about molecular biology. But just to show you that what's important is actually not the sequencing. Sequencing is quite easy. I hope there's not too many molecular biologists in the room, but sequencing is quite easy. The main problem is the post-processing of the data. I mean, when you have all those DNA sequences, you have to analyze the results, and that's the main problem. And after you've been doing the sequencing, you do a lot of computer work to get to the results which would be given by chromosome fraction calculation. I mean, we look at the amount of chromosome 21 sequences of the sample compared to the total amount of chromosomes. And therefore, we give the results like Z-score calculation. It's the amount of extra DNA from chromosome 21 compared to a normal patient with a normal fetus. Okay, so that's how the result is done. For us, the Z-score over 3 means that the patient has a baby with trisomy 21. So this is how the results present. We do the Z-score calculation, and if the patient, for example, there, 3 or 4, the baby has an abnormality. So how in France, we had 3 options. It started with the American hospital in Paris, who sent the samples abroad. But we wanted to have our own lab that can do those tests. And Jean-Marc Costa, who is a molecular biologist who works in Cerba, is performing the test in France with the technology which is quite the same as the one by Sequenom. So we've analyzed this test with our patient, and that's the first study coming from a French lab. So first of all, he did a preclinical test to see whether he obtained the same results as Sequenom. As you can see, out of 350 tests, we had a sensitivity and specificity of 100%. So we performed a clinical validation study with the help of 29 centers in France. It was a prospective, non-interventional, multi-center study. So we first sampled patients who were at risk, high risk, meaning they have increased nuclear translucency or other signs of ultrasound, and patients with moderate risk after serum screening in the risk population, previous chromosomal abnormalities, or maternal age over 38 years old. First, we did our study on a very high-risk population with a high prevalence to see whether it was a good idea to offer the test to all those patients. Sorry, am I late? No, so. And the blood sampling were performed at a mean gestation age at 16 weeks, mean maternal age 35 weeks, so quite old patient. And very important, the body mass index was 25, meaning much less than the American population. So French women have a smaller BMI, and this is very important because we're going to have no results because we have patients which have thinner. So we sampled 907 patients. Out of those, we had 0.6 no results, which is very, very low, and we analyzed 887 patients. We had only 0.6 no results, and out of those, 4 of them have a low fetal fraction because they have a high BMI, and 3 patients had chromosomal abnormalities. So we're thinking those patients, if they are a bit too fat and if there is a chromosomal abnormality, you have a higher risk of having a no results. I separate the results between patients who had a fetus with ultrasound abnormality and patients who were at risk after serum screening, because the prevalence in those populations are very different. So the results in the group with US abnormality, we have a 100% sensitivity and specificity, and we had 3 false positive for karyotype 18, for chromosome 18. And the main message I want to give you is when the test is positive, you have to do an invasive test to control the non-invasive test. Okay, this is very, very important because there is a small amount of false positive test. In the serum screening group, and the other important information is that more than 6% of patients had another abnormality than trisomy 21, 13, and 18. And this is why we think that the group of patients with abnormal nuchal translucency or chromosomal abnormality is not an appropriate group for NYPT. Okay, we should not offer those tests to those patients because we're going to find nearly 7% of other abnormalities. So I think NYPT is not supposed to be offered to patients with nuchal translucency. On the other hand, in the group with serum screening, a patient at risk after serum screening, we had also very good results. We had 1 positive, false positive for trisomy 21, 1 false positive patient for trisomy 18. As you can see, the prevalence in this population is 1 out of 250, which is very high compared to a normal population. But in this group, we had only 3.1% of patients who had other abnormalities. So we can definitely offer this test, but with informed consent. And we must explain to the patient that we're not going to see a few amount of other abnormalities, and we don't know whether those abnormalities those fetuses had abnormal ultrasound. This means that the positive predictive value for trisomy 21 is 58%, which is very, very, very good compared to the 5% we have for serum screening. The false positive patient for trisomy 21, we absolutely don't understand why we had this. The fetal fraction was really high, and one of the hypotheses is that the mother was also trisomy 21 for a few amount of cells. Okay, and the false positive for trisomy 18, the baby had an abnormality of the chromosome 18, so it doesn't really count for a false positive. So the conclusion of our study is that in the serum screening group, 95% of the sampling could have been avoided if we have used this test as a screening test. When US scan shows an abnormality, NYPT should not be offered to patients. And patients should be aware that 1.5% of chromosomal abnormalities will not be diagnosed, and this is very important. And as I said, any NYPT positive results do need to be controlled by an invasive test. Fetal DNA is from cytotrophoblast origin, so we cannot give a karyotype of the fetus. It will always be for the placenta. It's not a real karyotype. It's equivalent to CVS direct exam target to trisomy 21, 18, and 13, which is very different from a regular karyotype. We will not detect chromosomal abnormalities without any ultrasound sign, different from trisomy 18, 21, and 13. We will not detect triploidy with this technique. We will not detect some of the mosaicisms when the chromosome which is in mosaic is very low amount. We will not detect microdeletion of duplication, and we will not detect monogenic disease at the moment with those tests. But we will detect confined anomalies to the placenta, like in CVS. Maternal mosaicism, we know, like in our patient, that probably she has a small amount of cells that are trisomy 21. We will also detect maternal tumor. There's a few publications on mother with, for example, Ewing sarcoma, which have abnormal chromosomal abnormality in their blood. We will detect them, and there is at least 3 publications of mother who had a cancer and didn't know it, and they learn it with this test. And we also have the same problem as if for the sex or the result of the vanishing twin. Okay, because if the twin that has stopped was trisomy 21, there will still be some DNA in the maternal blood. So should we use this test as a screening or diagnostic test? For the moment, we have the screening test here with the screening plus nuchal translucency, and the gold standard is CGH. Okay, it's not anymore karyotype. Now we should do CGH. So a screening test is offered to a population without any known risk, while a diagnostic test is a test offered to a population with symptoms or at risk, and then a diagnostic test is offered after a screening test to determine the definitive diagnosis. That means that today, when we do a whole genome test, we are very, very close to karyotype, like in CVS. Okay, so is it a screening test or a diagnostic test? At the moment, it's a screening test. Why? Because if it's positive, you need to control with an invasive testing. And at least it would always be, because we need to accept that we do a karyotype like in the CVS, not like in an amnio. I'm going to skip on that. So last week, there was this paper published in New England of Medicine from Diana Bianchi team, and they perform a comparison between NYPD used as the first screening test and the regular screening test. And they have shown that in general population, meaning with the very low prevalence, we have a positive predictive value of 45% compared to 4.2% with the regular screening. And their conclusion is that we can offer today this NYPD in replacement of the actual serum screening technique. Okay, this is the first study in general population. It is not perfect, but it's shown that the sensitivity and specificity of the test is the same in the general population and in the high-risk population. And this is very important. So just one word to tell you, to remind you that this test doesn't mean we should not do ultrasound anymore, because of course we can pick up a lot of things on ultrasound. And I would say that if we choose to replace the serum screening by the NYPT, it increases the importance of the ultrasound, because we will need to pick up those 0.5 abnormalities that we won't see on karyotype, and of course, if there is ultrasound abnormality. In France, more than 50% of abnormal karyotype comes from detection of abnormality. That means there is still a place for invasive diagnosis, but only when there is a chromosomal abnormality, when there is ultrasound abnormality or an increased nuchal fold. So the cost evaluation, there is a few papers that have, which are simulation, that have shown that probably it would not cost much, because we're going to reduce the amount of sampling, reduce the amount of karyotype done, and reduce the amount of miscarriage. And when we look at those figures, basically they're the same whether you use the regular screening or the NYPT, but you reduce the amount of false positive by 95%. That means you reduce the amount of sampling by 95%, and you reduce the number of miscarriage by 99%. That's why in France, at the moment, we offer the test to all patients. When they have an abnormal serum screening, we offer the test. But the nuchal fold needs to be normal. Otherwise, we perform a karyotype. Because in this group, there is too many abnormalities that we won't see with an IPT. Okay, so for us, it's only patients that have an increased risk after serum screening. One thing is very important, there is no direct-to-consumer testing in genetics, in prenatal diagnosis. All patients need to be need to have a consent, need to see, they have a consultation with a genetician or an obstetrician and be informed of all the risk of this test. To conclude, NYPD is a screening test, okay, and not a diagnostic test at the moment. Any positive results will be controlled. High cost induce unequal access to care, because at the moment in France it is not reimbursed by the social security nor by the private insurance, and it costs 800 euro. So only patients that have money can have access to this test, and that's not possible. We need to find a way to stop that. It increases the importance of ultrasound, and probably it will replace serum screening by improving the detection rate, because actually by using the way we're using it in France, we're using a very accurate test after a less accurate test. That means we won't change the number of fetal trisomy 21 diagnosed, which is stupid, but it's like this. There is less false positive results, therefore less sampling. There will be a loss of information, and patients should be informed. There is a high cost. It's going to cost a lot, at least at the beginning. And it will not be easy to explain to doctors and to patients. But what's next? This is a moving target, because I just give a talk of 30 minutes on the subject, and probably I'm already has been, how you say it in I mean, probably it's already too late, because this technology is going so fast that there is some companies that start to do the whole genome on fetal DNA. In 2012, there is more than 100,000 patients that have been scanned in China, and today there is more than 2,000 patients that each day have access to NYPT. We will be able very soon to detect microdeletion and duplication, single gene disorder, and there is some companies that start to apply this technology to all genome and exome sequencing. So it's going to be very, very fast, and we have to catch up. Thank you.